أيام دول كانوا very exhaustive. But bear with me, this coming talk will take long. I just want to remind you that the achievement of anatomical reduction and durable fixation is your aim in the management of acetabular fracture. So this topic of hip replacement is a side issue. You should not aim at, however, and for this I just to remind you that in 1976, when I was a senior registrar in Exeter, I was the one who deals with acetabular fracture, and I got this lady. She was a middle-aged lady, and she has, if I remind you, a spare sign here, associated both column fracture. And at that time, I haven't got reconstruction plates and all that. So that was the reduction I have achieved. As you can see, this is the standard AO plate. And this is at that time what I call the Ectopic screw, which has been published afterwards in 1982. That lady, fortunately, her X-ray was sent to me after 26 years. And it shows a very satisfactory joint space, subchondral sclerosis here, but she came to see me in Plymouth because she lost trace of me and I lost trace of her. And she was doing very well, just on paracetamol occasions. But in 2 years' time, she was getting old by then. She asked me for a hip replacement, but I said to her, as she's in London, I referred her to Sarah Merhit Alwood, and she put a hip replacement for her. So keep in mind, if an anatomical reduction is achieved, the hip can survive for a long time. Now, hip replacement and acetabular fracture, you can do it primarily in day one, within the first 3 weeks. And this can be early in the 3 weeks as a result of a high degree of primary articular cartilage damage. It can be a comminution of the posterior wall, impaction of the dome, or associated head and neck fracture in old age too, that you want to get the patient up and going, and you don't want him to be, she can't manage frame and crutches and partial bearing. Or it can be delayed 4 weeks afterward trauma, and this can be a neglected fracture nobody has touched. Or a post-open reduction internal fixation. It could be an inadequate fixation or a complication of the fixation like a vascular necrosis, osteoarthritis and infection. Now the nice thing about the primary total hip replacement that you don't need to get, I'm so sorry. You don't need to get an anatomical reduction, but you need to get a stable column. You can bridge a wall defect by a buttress plate, and then impaction cemented, and you cemented old poly over an impacted graft. And I put this as my colleague Abdullah was still in the dream of cementless cup. And you can put a cemented old poly on a bulk graft. But this bulk graft I'm not in great favor of. This X-ray demonstrates the classic indication for primary total hip replacement, which is associated transverse posterior wall. And you have heard from my colleague from Bristol, who said that it has got 11% success rate in the 10 years result. You can see the dome, what's called the secant sign, dome impaction. You can see absent posterior wall and the neck fracture. The head is turned on its head, and you see a very rounded neck. So this head must have been out of the acetabulum. And this is a CT scan that shows absent posterior wall, a transcervical fracture, and associated transverse posterior wall. So what you're going to do, you have to fix the fracture. You have to reconstruct the posterior wall, and you have to autograft the acetabulum and cement old polycarp. So this would be the outcome. You put an iliopube screw, a buttress plate posteriorly, you get the patient's head of femur and marshalize it, impact it, and then cement old polycarp. You can see from this lateral projection that the buttress plate is a replacement of the posterior wall, while the graft will take and reform a posterior wall polyp. Some examples, this case from Abdullah Ahmad, and this is a comminution of the roof and a damage to the head, and he took the head and impacted, fixed with 2 screws, and he was in the era of doing cementless to the hip replacement. An old friend of mine is a teacher, the case. A teacher, 44-year-old, coming from Saudi Arabia in summer holiday. His content over in Tabuk, transferred through Jordan, and came to Alexandria, laid in bed for 3 months. I just like to draw your attention at the end of this course, try to see the subluxation or dislocation of the SI joint and the disrupted symphysis. When we come to the acetabulum, associated transverse posterior wall, and a damage to the head of the femur. So we follow the same rules. We have to fix the fracture, reduce if it is still mobile, and impact autograft from the head, a buttress plate, and a cemented hip replacement. This is 1 year. You can see how the bone has been taken and remodeled. You can see in this case there was a metal-backed cup, and this was a retrograde step in the development of the extra hip, as we have known later that the metal-backed cup, they get the uncoupling from cement and you get loosening at the implant cement interface. I'm sorry that the other side is not following the laser. So the principles of hip replacement. Internal fixation of the columns, if they are still ununited, this is in the neglected type. Bridging support of the acetabular wall, as you can see here in the posterior ilioischial plate, and autograft the acetabular wall defect with or without extra allograft, and cement a total hip replacement. Few cases, mainly by Abdullah Ahmad, has had uncemented hips with a bulk allografts. Examples here, you can draw your attention. This is 1987. Left, no surgery. 88, a vascular necrosis, no posterior wall. Now, this is a buttress plate posteriorly and an autograft, 1989. This hip survived this lady all her life, as she died 4 years ago. She was the mother of a colleague of mine. You can use the mesh fixed with screws and impaction autograft to reconstruct a wall defect. I'm not in favor, I'm so sorry, I'm not in favor of the Pabrowski classification of acetabular defects. I can't remember it myself, it gets very confusing. I follow the Antonio, the AOS 1989, segmental cavitary. Segmental can be marginal or central. Cavitary can be marginal, central. Contained cavitary defect or uncontained. Or combined of both. Pelvic discontinuity. I don't know what on earth they put arthrodesis in the classification of acetabular defects. I don't think it has got no rule at all in this classification. Some examples, some of the metal work put in acetabular fracture, you can't see any difference in the displacement of the fracture except the metal work. Still, the central displacement had an autograft very satisfactorily, and believe it or not, the patient problem completely disappeared except for this screw that has produced a foot drop on the other side. Transverse neglected fracture, you can see the plate added nothing but more metal work to the X-ray shadow, autograft and allograft to reconstruct this acetabulum, cemented total hip replacement. So the principle of reconstruction, support and bridge the posterior wall defect. Not advisable to remove the internal fixation devices except if it is in the way of reconstructing and fixing your acetabular component. Autograft the defect from the ipsilateral head, but if you need, you have to keep in mind the allograft at hand. And cement total hip arthroplasty. I put that slide because sometimes the defect posteriorly is quite big between the bridging plate, buttress plate, and the floor, complete action posterior wall, and you can fill that gap with a mesh before impacting your allograft. Now the difficulties after previous open reduction internal fixation. There is a higher incidence of infection because, as you know, more surgical procedures can produce more incidence of infection, higher incidence of sciatic nerve injury, and as the one in Pittsburgh, Danamir said, the double shock syndrome. You can have some minor lesion, sciatic nerve, in the primary procedure, and like some numbness in the foot, some weakness in dorsiflexion, despite they have full dorsiflexion. If you go in again, please warn the patient that he is highly liable to get a sciatic nerve injury. You get more stiffness in these cases, good abductor weakness, because the abductors have not been working satisfactorily before, and interference from the previous metal hardware that has been put there. I think I jumped slide. What? Here we are. The primary cases, as you can see, are 5, and I share only very few in this, mostly cases of Abdullah. The delayed primary, I got the majority of that with the inadequate internal fixation and some of the complicated open reduction internal fixation. The reconstruction is mainly impaction graft, cemented cups. The bulk and cemented, but the cementless has been mostly of my colleague Abdullah Ahmed. The results, according to Merle, Dubinier, and Postel, doesn't give you the exact clinical picture because you assess pain, function, and range of movement. And the patient can get easily 666, But nowadays, I don't think that work will be accepted for publication. You need to have the Oxford hip score, because any weakness of the dorsiflexion, walking with a stick, the activity of the patient can affect the score at the end. Now the complication. Ectopic newborn formation, despite I put it here, I didn't find it a great problem, and we give them endomedicine routinely after such procedure. Abductor weakness, some cases still relying on one stick. Sciatic nerve injury, as I told you, the double shock syndrome, 2 cases, not recovered, and more likely to happen if the primary procedure results in a slight affection of sensory or motor weakness. So please examine the patient carefully before you embark on the secondary procedure, as there may be some neurological affection there. Infection, of course, a great problem. 1 case treated by repeated debridement. 2 cases have 2-stage revision, and 1 case, as I mentioned, uncoupling of a metal backed cup. Now, I would like to show my gratitude to all the organizers of the meeting and the course, headed by my colleague and friend Hazem Abdul-Azim, and we have to all show our appreciation to the hard work he has been involved in, and our appreciation is to give him the show of hands. Thank you very much indeed.
Thank you, Mr. Halawa, for this nice presentation. Any question for Mr. Halawa? Yes? Would you accept some questions?
Yes, please.
I have 2 questions for you, sir. First question, in case of neglected transverse fracture, can I use the ilioischial cage as a means of bridging the defect instead of plate?
You said the ilioischial cage?
Ilioischial cage, like Birch Schneider or modular cup.
Yes, you can.
So I can give up.
It all depends on the mobility of this segment. Usually in neglected cases, there's some fibrous tissue, right? So I find the Birch Schneider is difficult to apply, particularly if you want to put the ischial part in the ischial. So it's easier for me to have an external fixation like plate or iliopubic screw. As I said, you don't need to achieve an anatomic reduction.
Second question, why is it not advisable to remove the internal fixation device in the absence of infection?
Why not to remove it? Because number 1, it's sometimes very hard to get at it. Number 2, you may find difficulty in removing it too. As you can see in one of the cases, is done through a modified stopper approach. A primary stopper is easy, but to go in again through the extraperitoneal approach to dig these plates out, it would be a hell of a job, and I wouldn't advise it without having a vascular surgeon with you.
But if, what about